we looking there? We'll go with it. Hi everybody. Thanks for joining us this afternoon. My name's Nikki Bryan. I am one of the infectious disease providers here at WVU in Morgantown. And so one of the hats that I wear is I work in our Ryan White Positive Health Clinic and help take care of people with HIV. And today I was asked to chat a little bit about HIV and syphilis, which is a very timely topic, I feel like. All right, so just a little bit of background. So syphilis is a sexually acquired infection. So it has plenty of the similar modes of transmission compared to HIV. So co-infection is definitely something that we see happen. But it sort of has sort of a weird kind of clinical presentation. It has these different stages of clinical disease that are separated by periods of latency where the patient doesn't really have any symptoms and for all intents and purposes, wouldn't know that they had any type of infection at all. Severity and complications may be more common in people with HIV, but for the most part, and we'll go through kind of break down some different clinical manifestations. For the most part, they're very similar in both of these populations, but there are some things that can be more aggressive or look a little bit different in people with HIV. They can have greater organ involvement. They may have sort of some atypical, particularly rashes or skin manifestations, and they can have more rapid progression throughout the different stages of disease, including neurosyphilis. In addition, you can also sort of see the reverse a little bit. We also see when people with HIV are diagnosed with syphilis, we see changes in some of their laboratory markers. We can see changes in their HIV viral load. We can see that has an effect on their CD4 count. How clinically significant these are really sort of remains to be seen, but we do sort of see an interplay with both of these infections. This is just sort of kind of some of those statistics in a graph. So again, since the 1940s, we sort of had overall cases of syphilis were pretty high. Once we really had a good handle on how effective penicillin could be at treating it, those cases kind of really decreased until the early 2000s, and then they've been on the rise again. If you take kind of that small window there after 2011 and blow it up a little bit, you can kind of appreciate that increase a little bit better. So nowhere near where we were in the 40s, but definitely not headed in the right direction the past several years. As far as who's impacted, so again, predominantly men, going back from 2012 to 2021, but we're also seeing those increases in women as well. As far as what racial and ethnic groups are mostly being impacted, so we do see it impacting racial minorities, including Black, Asian American, Hispanics, and Latinos as well, more compared to whites. So this is I like this map of the US because it really shows you that this is happening across the country, that we're seeing these increased rates in syphilis. So this is just kind of taking you through time, how the rates of syphilis looked in all 50 states starting in 2012, all the way through 2021. And we really do have pretty reliable data on this because syphilis has been a reportable illness to local and state health departments and the CDC for some time. So this is probably pretty reliable data that these increases are real. Going along with increases in syphilis among men and also women is we're also seeing increases in congenital syphilis, which is a lot of times considered the canary in the coal mine as far as having disease control. So we are seeing increased number of cases in women, and so we had a little over 2,000 cases of syphilis reported in women in 2020, and then going along with that, there were almost 150 stillbirths and infant deaths related to syphilis infection. So that's not just congenital syphilis or was diagnosed with syphilis, that's actual stillbirths and infant mortality directly attributed to syphilis. Going along with the racial and demographics, congenital syphilis does seem to be affecting more ethnic minorities, as well as people with substance use disorder and those who live in poverty. And so in many ways, it really is a public health emergency, particularly given that we've known for some time how to very effectively manage and prevent some of these outcomes. So how does syphilis impact those HIV parameters? So syphilis can impact both the immunologic parameters of HIV and the virologic parameters of HIV infection. So when we're caring for patients with HIV, kind of our two big guideposts are, first of all, their HIV viral load. So how much virus is in their blood, and we can quantitate this with PCR studies. Our goal when we have patients on therapy is that they should be undetectable, where if you send a PCR, you wouldn't even be able to identify any HIV virus or very trace amounts. And when we're treating people with HIV, and then the other is their the measure of their immune system, and this is mostly done with assessing their CD4 counts or their T cell counts for CD4 positive cells. So patients with syphilis actually have been found to have an increase in the HIV viral load around the time of their HIV diagnosis. This is definitely true in patients who either weren't on treatment or weren't fully suppressed on their treatment, but it has also been shown to have a little bit of a viral blip even in people who are reliably taking HIV medications. And CD4 counts can also do seem to transiently decrease following the syphilis diagnosis. In addition, when you look specifically at people that have uncontrolled HIV and a detectable viral load, we see that the more invasive the syphilis is, so all the way up to the point of neurosyphilis, we'll see higher levels of HIV in the spinal fluid in patients with neurosyphilis, indicating probably because of some of the inflammatory response that's triggered in the CNS by syphilis is going to pull some of those HIV positive immune cells there as well. So what's the clinical significance of that? We're not really sure. I mean, for sure, the higher HIV viral loads can be playing a role in facilitating HIV transmission in somebody who has syphilis. But it doesn't seem that these sort of transient changes in their numbers really kind of impacts the long-term trajectory of the HIV infection. That's really going to still link back to whether or not they're able to start antiretroviral therapy and get virologically undetectable in what their CD4 count is. But it does kind of indicate that there's an interplay with both these infections. Okay. So what is how does antiretroviral therapy impact syphilis in people with HIV? So in general, across the board, people who are on effective therapy, on potent therapy, are going to have better outcomes if they do happen to acquire syphilis. So use of, if they're already on HIV medications and their HIV is well controlled and they have a good immune system prior to having any diagnosis with syphilis, that's really going to decrease the odds that it's going to progress and they'll develop neurosyphilis. In patients with neurosyphilis or ocular syphilis, eye syphilis, individuals who are receiving treatment are 4 times more likely to have normalization in their spinal fluid parameters for infection, and as well as symptom resolution. And some of those can be really devastating infections. There's definitely people who have permanent vision loss related to ocular syphilis and can have long-term neurologic damage from neurosyphilis. Even after they've been treated, depending on what their clinical course was and when they were able to get diagnosed and treated. Individuals on HIV medications with immune recovery, so they also have a really robust CD4 count, are also less likely to have what we'll talk about toward the end when we talk about testing, but serologic failure after they have their syphilis treated. So more likely to indicate that the treatment was successful. So moving on to clinical manifestations. So early in the HIV epidemic, before we kind of had really good, reliable therapy, and patients were really struggling with opportunistic infections like pneumocystis pneumonia or cryptococcal meningitis, and really what we were trying to do was buy time and support the immune system until we couldn't anymore. So early on in those days of the HIV epidemic, there were a lot of case reports of very unusual or atypical or severe presentations of syphilis that were noted. When larger studies were kind of looking at it in a big picture, it really seems that by and large, most of the clinical manifestations are going to be pretty similar for people who have HIV compared to those who don't. But there are a few things that are worth noting at each stage of infection, and we'll spend some time going through that. So for early syphilis, that's really defined as typically either primary or secondary syphilis, are both going to be kind of defined as early syphilis. And usually you're talking about somebody who's acquired the infection within the previous year. So early primary syphilis, that's the very initial stage of syphilis. That's typically characterized by the syphilitic chancre, which is an ulcerative lesion. It's almost always described as painless, so can often be asymptomatic, particularly in female patients who may not realize that they have it. And then there might be a little bit of associated lymph nodes, sort of rubbery lymph nodes in that region. Individuals with HIV infection are more likely to have potentially multiple lesions, and more likely to actually have something that can be painful. So it can look a little bit atypical. Sometimes it could even can even look more like a herpes infection, which is more classically to have more lesions and be more painful. So you don't want that to kind of throw you off or not consider syphilis in that differential. Secondary syphilis, that's the one that we most commonly associate with a rash. And that really takes place because the treponema organism, after initial infection, it sort of disseminates very diffusely. And so that dissemination can have symptoms along that stage as well. Skin rash is really kind of the one that I feel like we kind of get used to looking at and thinking about. It often can involve the palms of the hands and the soles of the feet. But there can also be neurologic and eye manifestations at that stage as well. In patients with HIV, these early stages a lot of times can overlap. So you could have a patient who has a chancre, but is also coming in with a very diffuse rash. So they can overlap in addition to, or they could come in with a chancre and maybe have some meningitis type symptoms for neurosyphilis. So the stages get a little bit blurred. It's a little bit harder to kind of tease out, are you looking at primary infection or are you kind of more in that secondary, more disseminated stage of infection. In addition, the symptoms can be more severe, particularly some of the skin manifestations. So people with HIV can sometimes develop what's called ulceronodular syphilis, or malignant luz is another term that's been used. And these can be really severe ulcerative lesions on the skin. So in those instances, the diagnosis might actually be made by a dermatologist or somebody who does a skin biopsy. A lot of other rare manifestations have also been described, usually kind of in the realm of sort of the case report. So osteitis, so bone involvement, that's honestly something we typically think of when we're thinking about perinatal syphilis. But osteitis has been described in adults with HIV, as well as arthritis. Kidney involvement with glomerulonephritis or nephrotic syndrome, and then or also a hepatitis or liver involvement during those stages. So really could have a lot broader range of manifestations. So here's some pictures of some of these atypical findings. So that one on the left, so that's kind of showing sort of where you can have sort of multiple small chancres in the area as opposed to a single ulcerative lesion, and they can also be painful. So if you're seeing this patient in the clinic, you might also be looking, thinking, oh, that might look a little bit more like HSV. But if they have an HIV, it could also be a manifestation of syphilis. And then on the right, this is some of those ulceronodular skin findings. So those are pretty impressive skin findings that can develop in somebody with HIV infection, as opposed to kind of what we typically think of, which is that very diffuse skin rash. And then this is from the case report of a patient, 41-year-old male, who was found to have osteitis of the skull. So the arrows are sort of pointing to, instead of having that nice smooth skull, you're seeing these kind of sort of chewed out looking areas where you're not seeing that nice smooth bone. And then this was it on autopsy. This is actually very common finding in archaeology because, I mean, syphilis is a very ancient disease, going back, hundreds and hundreds of years. But it has also been seen in HIV patients as well. So these are some of those findings related to that in that case report. So later stages of syphilis. So again, this is sort of how the infection typically will progress if it's not treated. So later, or what we'll sometimes call tertiary stages of syphilis, and this can occur even years after the initial diagnosis. So if the patient isn't diagnosed at the time of the chancre, or they don't, or they have, they don't really have a typical secondary syphilis, or the diagnosis isn't made at that time, they can continue to progress. And so two key areas that can be impacted in people with HIV. So one is gummas or gummatous syphilis. So syphilitic gummas, that might be a really kind of old school term, but that's still what we use. And really what's happening is they're getting a granulomatous response, similar to what we might think of for something like tuberculosis or a fungal infection. It's an abnormal immune response to actually a very small number of the syphilis organisms. In people with HIV, these have been found to occur in the brain, in the spinal and in the spine, so CNS areas. But they also seem to have a shorter time frame to develop them. So they could go from the primary chancre to a gummatous lesion within just a few months, as opposed to what you would typically think of, which would be several years or even up to a decade before those types of lesions would develop. So it seems to be a much more compressed time frame before they see some of these later manifestations of syphilis. It can also see something similar with cardiovascular involvement. So what the classic cardiovascular finding related to syphilis is actually an aorta involvement or aortitis. And really what's happening is the blood, the aorta is so big that it has its own blood supply. So the aorta is supplying blood, but it also needs blood. And that's called the vasa vasorum, is the blood vessels that are supplying the aorta. And so those get involved and can actually cause aneurysms and changes and inflammation around the aorta. So cases of very rapidly developing inflammation of the aorta have been described in people with HIV. So it seems like some of these later tertiary manifestations can actually happen earlier in the disease process than we're typically think of looking for them. And so I do have some pictures of what those can look like. So on the left, this is a patient that had an oral gumma. So it's just kind of a very, very thick area. And I didn't have space, but they did have a follow-up picture after this patient received treatment, and it did resolve. And then this is what they, on imaging studies, these were initially thought to be brain abscesses. These ringed areas along the gray part, and here it is on MRI. You see a lot of these lighter areas that were actually found to be syphilis gummas in patients with HIV. For the aorta, so this was an area of aortitis. So what they're kind of trying to show you is these areas where it's a little, this is all this white is sort of blood kind of flowing through the aorta. And what you're seeing, these kind of areas where you're seeing some of these outpouchings, these areas where it's a little bit more dilated instead of kind of nice and tight and firm. Those are areas where they've developed inflammation around their aorta, which can be very devastating. So neurosyphilis, I sort of talk about it in its own time frame. We typically had thought of that as a later manifestation or more of a tertiary manifestation of syphilis, but the reality is it really can't. You can have nervous system involvement at any point along the disease process. So anytime after initial infection, they can have patients can present with neurologic involvement. Early neurologic involvement is more frequent in people who have HIV. And they do have some outlined risk factors within that population. So if they have a CD4, that T cell count less than 350. So honestly, I mean, a lot of times a 350 CD4 count or a 300 CD4 count we'll think of as, oh, that's pretty good. They're doing pretty solid. It's usually that 200 cutoff that we think of that they would be at risk for opportunistic infections. But less than 350 is sort of the cutoff to think, they could potentially be at risk for neurosyphilis. If they have a very high RPR titer, so the test result when it's quantitated for syphilis, if that comes back very high, greater than 1 to 128, they're at higher risk for neurologic involvement. And then for whatever reason, male gender also seems to be at higher risk for neurologic involvement early on. When we just find early, it just really means that they're developing signs or symptoms of neurologic involvement within a few months of their infection. And this can be a whole host of things. It can be eye involvement, hearing, they could have auditory changes, cranial nerve abnormalities like a Bell's palsy, or pain like a trigeminal neuralgia. They can have mental status changes, could just present with confusion, meningitis type symptoms, or even a stroke. So it really can run the gamut of different ways that these patients can present to care. Later manifestations, we typically think of those taking place at least a decade, maybe more than a decade, so anywhere from 10 to 30 years after they initially have acquired the infection. And these are two kind of very key terms that go back a really long time, and because it's really going to refer to involvement of the brain, where the term that this isn't my term that they would use for a long time was general paresis of the insane, or involvement of the spinal cord, where they would have very classic findings of tabes dorsalis. And so those, when syphilis was much more a natural history of the disease, those were much more commonly described. And it can also be asymptomatic, and that's particularly true in people with HIV. There have been estimates that anywhere up to a third of people with HIV may have asymptomatic neurologic involvement at the time of their diagnosis, particularly early on. As far as eye involvement goes, so syphilis can, just like neurologic involvement, syphilis can affect the eye really at any stage. It can be early, it can be late. It is more common to occur among people with HIV compared to people who don't have HIV, and it can occur by itself or with or without neurologic CNS involvement. The symptoms can also run the gamut, so could present with kind of just decreased visual acuity, just aren't seeing as well, redness, pain, just light sensitivity, or even just random floaters in their vision. So all of those things could be related to syphilis. The two most common exam findings are uveitis. Syphilis in general, that just became a buzzword for me. Whenever I heard uveitis, I would think syphilis. It's just a lot of inflammation over the anterior part of the eye. And also optic neuritis. Now, I will confess I am a bit spoiled because we have great ophthalmologists here at WVU, so I frequently rely on them to say that that their exam findings when they do dilated eye exams or really get a good look in the back of the eye are consistent with syphilis changes. So we're real fortunate for that. I would so if I've ever had an HIV patient that had these symptoms, I would have a pretty low threshold to get them checked out by to test them for syphilis and to get them checked out by an ophthalmologist. It really does impact treatment, as we'll touch on, so a little bit later. So it does matter if you determine if they have eye involvement. Okay, so diagnosis. This is the worst part of syphilis, I won't lie. This is my least favorite thing to do or to question is trying to diagnose syphilis. It's not a good time. But this actually, in the next several slides, I actually have the citation there at the bottom of the slides, and I will share these with Kelly and Chantry and they can send them out if anybody would like it as a reference. But these are actually from the MMWR. So this is actually from the CDC's updated guidance on syphilis testing. And again, the link to that article is in the blue box at the bottom of these slides. So if you want to have that as a reference, but we'll go through them. So the challenge, I'll start with the challenge and then kind of different ways that labs approach. The challenge with syphilis is you can't grow this organism in the lab. So when somebody has a staph infection or an E. coli infection, I know that because they give a specimen, we do a skin swab or a urine specimen, and we take it down to the lab and we put it on plates and we see the bacteria grow and we name it, and that's just very, very nice and concise. It's not completely perfect, but it works. In syphilis, we can't really do that. So most of the time, we're relying on basically the immune response, basically antibody development to the organism itself in order to determine if it's there, or visualizing it with special stains in some way, and I'll show you that as well. So classically, the way we would do this is we had a couple of different algorithms for sort of how to decide, is this immune response, are these antibodies actually truly responding to syphilis? Is that what I'm detecting? Or is it, they got infected with something else like Lyme disease, which is also a spirochete, and we're just seeing some cross-reactivity. Like, how do we decide that this immune response really is consistent with syphilis? And so usually what it is you go through a series of tests to make that determination. Typically, and what I learned back when I was in school was this traditional algorithm. And so really that starts with, they call it the non-treponemal test. That's the RPR. So if you learn the RPR in school is the way to test for syphilis, that was the traditional algorithm. If that's positive, if that's negative, then we say syphilis isn't likely and you stop in this algorithm. If that's positive, then you go on and do a confirmatory second test. And then if that's positive, you say it's probably, they probably either have had syphilis and they're partially treated, or they probably have it. If it's negative, then that says syphilis is unlikely. So it kind of takes you to these pathways to try and get at least like 2 positive tests. A lot of labs including our lab here at WVU, have gone toward this reverse algorithm, and I'll show you why in a bit. Where they kind of start with a treponemal test or an antibody test specific for syphilis with an ELISA-based assay. Rather than that RPR test. So if that's positive, you do that first. If those are negative, you stop. If that's positive, you go forward with the RPR. And then if that's positive, you say this is probably syphilis. If that's negative, then you can do a third test and see if you can get to 3 positive tests. So there's advantages and disadvantages to both algorithms, but the most important thing is for whatever lab that you're sending your tests to, for you to understand which approach they're using, so you can understand the results that they're telling you, and when to act on those and how to act on those. So what are some of those advantages and disadvantages? So the RPR is been around for a really long time, so it's fairly quick. The reagents aren't very expensive compared to doing some of the ELISAs. But it requires a little bit of handling. And so that's really probably the biggest advantage. I'm just going to highlight what the big advantages are that most labs like this reverse algorithm. And the biggest one is that initial screening test is automated. So most clinical labs can do ELISAs very, very quickly without having to have a lot of hands-on time by the medical technicians. And so it makes it a little bit quicker for them to put screening tests through that. But if you have a population that's very high risk, or has either high risk for syphilis or has high rates of previous infection, that can actually kind of add to your burden a little bit. But it's really this kind of rapid throughput that is typically what labs prefer about the reverse algorithm. The other advantages is you can sometimes have false negatives with your RPR in patients who have very active syphilis and a high burden of organism, and that's called prozoning. And so sometimes if there's a potential for a prozone phenomenon, you have to have them diluted out if you have a very high clinical suspicion. So that's also additional handling that's not an issue with the first screening test. So interpreting those tests, so again, it's real important for you to recognize which one and which algorithm and which test the lab is reporting out to you. If they're starting with an antibody test, that test will become positive very early in infection. And then it stays positive forever and ever and ever and ever and ever. So I have patients that we check for syphilis every year, and I'll explain to you why. But that antibody does not go away. Once that's positive, that sucker's positive. It doesn't matter how many times you treat them, that stays positive. It's almost not worth it to recheck that in somebody that you already know has a prior history of syphilis. As opposed to the RPR or the non-treponemal test, so they will turn positive. If they don't undergo treatment, they'll stay positive. Now the titer might vary a little bit, but it will always stay positive. Most people, if they get treated, it will within a year that will go back to being completely negative. Some people, even if they're treated, it will decrease significantly, but it's never completely negative. And we call that being serofast, and we really kind of monitor for changes in that. So you can see why testing for syphilis and diagnosis of syphilis is not my favorite thing to do. It can get really, really confusing, particularly if somebody has had infection before and been treated before, to interpret some of these results. Other ways to test for it. There are other ways if you want to look for the organism or visualize the organism. So these are ways that we would use mostly on a specific clinical specimen. So all of the other screening tests, those are all done. Those are lab tests. Those are done on blood. Again, because you're looking for that antibody response. But there are other ways to look for syphilis. If you had that patient with the large skin lesion, I mean, truthfully, from a clinician's perspective, that could be a lot of different things. If that was an immunocompromised patient, patient with HIV and very low CD4 counts, that could be fungal infections, that could be mycobacterial infections, in addition to syphilis. So there's a lot of different things that could be. So if you have specific clinical specimens or the patient with the chancres, there are different ways to visualize the organism. The classic one that's been around the longest is dark field microscopy. It's not very sensitive. You can definitely miss it. But if you see the organism there on the appropriate clinical specimen, that would be diagnostic. You can increase the chances on some of your specimens with immunofluorescence, where you take an antibody that glows in the dark and have that stick to the organism and it'll show up. You could do it on biopsy specimens. So if you had a patient with an abnormal skin finding and they got a skin biopsy, you could see it on that. We've had patients with a tongue lesion. I guess probably been like almost 10 years ago now, that nobody could really figure out. And we went back to a biopsy and did immunohistochemistry staining on it for syphilis, and that came back positive. And you can also do PCR on some of these specimens as well. So again, this is from the CDC guidance. It's really kind of helping labs determine like what specimens you can do these things on and how you need to store them in order for the test to be most effective. But this is what they can look like. So this is the organism. So yeah, it's very, very long and kind of a curly Q. So that's the spirochete. So anything that's termed a spirochete is going to look like that. But it's very skinny, and that makes it really hard to visualize. This is a similar picture. So this is on immunofluorescence. So these organisms have been tagged with a specific antibody that glows in the dark. And then this is immunohistochemistry, same thing, only instead of glowing in the dark, it's just going to light up with this sort of brown looking stain on the background of the rest of the tissue. So these are just different ways that we can kind of look directly for the organism on specimens if it's not really clear that the specimen is related to syphilis, or if we're not really sure about that, or the blood test is a little bit not diagnostic or not as useful. So treatment, So as challenging as the diagnosis part can be, the treatment's easier because it's pretty much the same for people with HIV and people without HIV. And the preferred treatment, again, for every stage of syphilis is still going to be penicillin. For neurosyphilis and ocular syphilis, we would administer that IV over an IV infusion for at least 14 days. But versus, early syphilis, late syphilis, it might affect how many doses they get or how it's dosed, but it's still penicillin. Individuals with HIV are at higher risk for treatment failure, and they are at higher risk to progress onto neurosyphilis. But again, drug of choice is still going to be penicillin. There are alternative agents for the treatment of syphilis that have been emerging. And so the two most commonly studied one is doxycycline, and a fair number of people, particularly for early uncomplicated syphilis or early latent syphilis, have been getting treated with doxycycline and also ceftriaxone. There's been a lot more interest in alternative agents because there's been frequent shortages, particularly the benzathine penicillin and even the IV penicillin G. And so with a lot of drug shortages that have been happening through the years, as the cases have been increasing, there have been looks of ways to treat people alternatively. Neurosyphilis and ocular syphilis, you still really want to do IV penicillin G. And I didn't mention it here, but pregnancy, anytime a pregnant patient is diagnosed with syphilis, the treatment has to be penicillin. That's the only one that we know for sure is gonna prevent the neonatal transmission is with penicillin. But for some of the other less complicated ones, these other two agents have been looked at. They have not yet made their way to the actual STI treatment guidelines, but those guidelines are still a little bit old, so they're listed as, well, if you really have to. If patients are treated with one of the alternative regimens, either because of a drug shortage or an allergy, or they just can't come in and get injections reliably, then you really should monitor them closely and make sure that their titers resolve. And have a low threshold to retreat them with penicillin if needed. So this is a table. I won't take credit for this. This was from Up to Date that kind of goes through each of the stages of syphilis. Again, what's the preferred formulation of penicillin, how many injections you would recommend. So again, early syphilis, uncomplicated or early latent, it's usually a single IM injection of benzathine penicillin versus later disease. If the disease has been present for at least a year, you would do 3 injections of those. And then the alternatives. Again, for neurosyphilis, really you're kind of focusing on penicillin G, potentially ceftriaxone as an alternative, but again, there's just still not a lot of data behind that. And hasn't made its way to the actual CDC treatment guidelines. So monitoring for response, so we do need to do that. So we do need to monitor for treatment response. And that should be the case whether the patient has HIV or not. But individuals with HIV do need to be monitored a little bit more frequently, again, because they have a higher risk for not responding to treatment and higher risk for progression to longer-term disease or CNS involvement. So they should get a baseline RPR done on the day that they get treated, and then you can use that as your basis to comparison. So if they had a diagnosis, a week or 2 ago, but it's just taken that long to get back into clinic to get through treatment, you still want to repeat that lab test on the day that you do treatment so that this was my RPR on the day of treatment, and then you can compare back to that to assess their treatment response. For early syphilis, they should have a repeat RPR done 3, 6, 9, 12, and 24 months. For late syphilis, it should be done every 6 months up to 2 years. And then this can happen in all patients, but it is more common in people with HIV, where they can sort of have a persistently positive titer The titer should go to non-reactive, but some people, particularly if they have HIV, they'll sort of smolder with this titer of like 1 to 1 or 1 to 2. As long as they've had at least a 4-fold decrease and they're kind of hovering in that same titer range, we just kind of say, yeah, that's probably, still their treated syphilis, and we don't kind of get too worried about that. And we call that being serofast. It's just they don't really completely go to a negative titer. As far as screening and prevention, so all individuals with HIV infection should be tested for syphilis, regardless of any symptoms they're having, because it can have those long periods of latency and because they have such shared transmission risk. The current recommendations are at least upon diagnosis with HIV and when they enter care, and then at least once a year. More frequently, though, if they have ongoing risk behaviors, and that can be multiple sexual partners or unprotected sexual contacts, and things of that nature. After an exposure, so if they were exposed to someone who is diagnosed with syphilis at any stage, they should also get tested for syphilis at baseline. But a lot of times, if they are certain that, yes, this partner I had, I was confirmed that they had syphilis, you may, even if all that's negative, you may go ahead and treat them because it can take time for those antibodies to form. And it's better just kind of go ahead and empirically treat them while you have them in care with you, rather than kind of waiting to do follow-up testing. I had a patient one time in the hospital that had been exposed, and she was pregnant. And so all of her testing was negative, but because we knew that she had been exposed, we actually went ahead and treated. So there are some circumstances where if you have a known exposure, you would probably go ahead and proceed with treatment. So in summary, so syphilis and HIV can share similar transmission patterns, and syphilis can facilitate HIV transmission. These clinical manifestations can be very similar, but they can be more severe in people with HIV and progress more rapidly. The diagnosis and treatment are very, very similar for people with HIV and those who don't have it. And then individuals with HIV should be undergoing regular screening for syphilis upon untreated care, and then at least annually, if not more often. And then if anybody has any questions or comments or anything to share, I'd be happy to chat with you.